A number of best practices that have been identified in initiating antiretroviral therapy among women are shown on this slide. It is in recent years become important to initiate antiretroviral therapy as soon as possible after establishing a diagnosis. Indeed, there are successful programs that initiate antiretroviral therapy the same day as diagnosis. However, I would say that it is critically important to personalize that to the individual situation of the patient and the availability of doing this in any particular community. 3 barriers that are important to address before antiretroviral initiation are shown: depression, cognitive problems, and substance use and alcohol. Also important is a review of social support, health insurance, and the ability to assure continuity of antiretroviral therapy once prescribed. Nothing is worse for the patient than to get a prescription and then subsequently find that the health insurer will not cover that particular drug. So that it's really, I think, incumbent on us to figure those things out ahead of time. Also important for women of childbearing age is a discussion of options for pregnancy if pregnancy is desired, and certainly the availability of contraception if that is a choice of the women. It's important that these things are identified before initiation of treatment because they affect selection of the antiretroviral agent, as we'll discuss. Shown in this slide are the most recent recommendations for initiation of antiretroviral therapy. It's on the left side is the Department of Health and Human Services, the US recommendations, and on the right are the International AIDS Society, and they're remarkably similar. Both sets of recommendations really are focusing on integrase inhibitors, the newest class of antiretroviral agents, and a class that's really been associated with excellent tolerability and convenience. The alphabet soup is shown, but basically, if you look at the DHHS, bictegravir, dolutegravir, and raltegravir are the 3 integrase inhibitors that are recommended in combination with 2 nucleoside reverse transcriptase agents, either tenofovir or abacavir, and then either 3-TC or FTC. And as you can see, they're remarkably similar to the IAS recommendations. In the discussion before selection of antiretroviral therapy, when clearly the woman has said she has no plans to conceive, and I would suggest that no plans to conceive really includes then a plan for contraception, or obviously in the event if the woman is not really of childbearing potential, if she has had a hysterectomy or tubal ligation. I think that counseling about safe sex practices is really critical. And a pregnancy test should be conducted in all women before prescribing antiretroviral therapy. The choice should be, guideline driven. If oral contraceptives or hormonal contraceptives are to be prescribed, one needs to consider that some antiretroviral agents, most commonly the boosted protease inhibitors or efavirenz, may have drug interactions with some antiretroviral agents. Though by and large, one of the attractive issues with integrase inhibitors is they have fewer drug-drug interactions. If a dolutegravir regimen is selected, the patient should be advised of the potential birth defects that have been recently associated with this drug, and we will discuss those in just a minute. Other considerations when selecting an antiretroviral therapy should be the pill burden. There are many 1 pill, once a day regimens, though some even in the DHHS recommended guidelines have more than 1 pill. Dosing frequency, we talked about the potential for drug interactions, but there are others, for example, comorbidities. Some antiretrovirals, for example, the bictegravir, tenofovir, lefenamide, and M-tricytidine is not recommended in individuals who have a creatinine clearance less than 30. So it's important to really identify if any comorbidities exist. Also important is to identify the presence of resistance to antiretroviral agents. Even though individuals may not have been on antiretroviral agents in the past, it's a new diagnosis. It is not infrequent that there is transmission of drug resistance at the time of HIV acquisition. And so a resistance test should be done for all individuals. And then special considerations, there are some regimens, though none of those on the top recommended list, for CD4 and viral load requirements. So, one needs to bear that in mind. And the other is that the HLA-B5701 testing must be done in the event that you are planning to prescribe abacavir. HLA-B5701 actually predicts occurrence of a hypersensitivity, which can be a life-threatening complication. So it's important to remember that.